Battling the opioid crisis. A town hall with ABC 17 News and Hot Talk 93.9 The Eagle starts now.
Thank you so much for joining us tonight for Battling the Opioid Crisis, a town hall meeting between ABC 17 News and Hot Talk 93.9 The Eagle. Thanks for joining us. I'm Marissa Holloway from ABC 17 News.
And I'm Brandon Rathert for Hot Talk 93.9 The Eagle. And we've been hearing from Mid-Missourians for quite some time now about this growing opioid epidemic. And I think more importantly, people have been wanting to know, how do we stem the tide here?
Yeah, and that's our goal tonight. Now, according to the Centers for Disease Control, nearly 600 people in the United States try heroin for the first time each day. Now, bump that number up to 4,000 people a day that are trying non-prescribed opioid painkillers.
As a matter of fact, right here in Missouri, about 1,000 people per year are dying from opioid overdoses, and that's just the prescribed opioids. The CDC tells us that roughly $55 billion a year is spent on battling this crisis, and that's not the illicit opiates, that's the prescribed opiates. And
we are lucky enough to have a wonderful group of panelists tonight who have agreed to join us for this town hall. We'd like to introduce State Representative Holly Rader, who is here, came all the way from Southeast Missouri today, so thanks for joining us. And also Troy Derby, thank you for joining us. He's a DEA agent from the Kansas City area.
And Dr. Brooks, that's how I know him, is Dr. Brooks. He's joining us here, and he has a unique story that he's going to be sharing with us tonight. And then we have a recovering addict who has been kind enough to come in. His name is Eddie. He's a local guy. He was in the throes of addiction for quite some time, and he's now been clean and sober for 4 years. And so we kind of thought it would be interesting to get his point of view on how we try to help fix this problem.
Yeah, so we'd like to thank you all so much for joining us. We really appreciate it. And I think we'll start by maybe just kind of going down the line and telling us, you know, why you're here and taking part in this today. Ms. Rader?
Yes, so I was raised in drug addiction. I was raised in poverty. One of my stepdads was a dealer, and but my children weren't raised that way. And so at 17, my daughter became an addict. And I think that raised in a two-parent home with, you know, both parents being in her business all the time. And so I think my story really shows the difference between, it doesn't matter what your background looks like, whether you're raised in the trailer parks or, you know, whether you're raised in middle, you know, America, two-parent home. And so I think that brings a different perspective to the issue. But then I'm also a state representative, and I've been pushing, fighting to get the prescription drug monitoring program passed. Missouri's the only state that doesn't have this. And so this is something that's been very important to me. I know that it's important to Missourians, and so many are suffering from our physicians just not having this important clinical tool.
All right, Ms. Rader, thank you. And Mr. Derby, thanks for joining us today. You're DEA agent. You know, tell us a little bit about why you're here today.
Well, first of all, thank you for the invitation. But I'm here to talk about this problem from a law enforcement perspective. What we actually do to fight opioid drugs from coming in, heroin, fentanyl, and just to talk a little bit about how dangerous those drugs are.
All right, Mr. Derby, thank you. And Dr. Brooks, we've spoken before, but if you'll let our viewers know a little bit about your story.
On June 2nd, 2015, I received a phone call from a neighbor of my son's who had found him unresponsive in his apartment, and he had passed away from a heroin overdose. It wasn't a month before that I had found out that he was actually using heroin. For months before that, I suspected that he was using something, and then found out early May of 2015 that he was using heroin. Got him into rehab. He was in rehab a month and then passed away 4 days after being released from rehab. I knew immediately when I found out he was using heroin that he was in for a fight of his life. You know, and we had real frank conversations about it, and he knew the consequences of what he was doing. He wanted to be clean, and he ultimately succumbed to the addiction.
All right, well, Dr. Brooks, we appreciate you being here. And Mr. Bunnell, if you'll tell us why you're here today.
I'm here just to hopefully spread some knowledge about prescription pill abuse here in mid-Missouri. I was a typical 15-year-old kid, started stealing opiates from my father. He passed away from an opiate overdose, and that's when I really started ramping up my use. I used heroin for the first time at 19 here in Missouri. Became a really big heroin addict, and finally got in trouble with the law and was able to get clean for the past 4.5 years. So I'm just hoping that what we're doing here will change somebody's life.
Well, we appreciate it. And again, thank you so much for being here. And we have a bunch of questions for you guys today. If you want to take it away, Brandon.
Yeah, I think I'd like to start with Mr. Derby, because I think a lot of us, we hear about this opioid epidemic. We've been hearing about it for quite some time now. But what's happening on the streets? What do you see from a DEA point of view? Make it real for us.
Okay. Well, I would start and say, to let the public know, you know, the heroin scourge just doesn't affect one particular group of people. It doesn't affect the poor. It doesn't affect the rich. It affects everybody. And so I would start with that. And so throughout all walks of life, we see a lot of folks that start with just sampling some opioids out of a medicine cabinet, whether it's at their family's house or a neighbor's or friend's house they're spending the night with. And from there, because of the price of oxycodone, it's very expensive. And so when they run out of money, the next thing, they look for something else. Unfortunately, heroin is significantly cheaper than prescription drugs, buying them off the street. We're talking about illegally possessed. So they move on to heroin. And so what we see now is the traffickers are bringing fentanyl, high-quality fentanyl, into our country. It's manufactured predominantly in China, brought here, and so a lot of the larger traffickers, they'll cut the heroin with fentanyl. And to give you an idea about fentanyl, fentanyl is about 100 times more potent than morphine. And certainly with any illegal drug, you don't ever know what's in that drug. You're buying it on the street. It's not prescribed by a doctor and filled by a pharmacist. So it's really potluck what you're getting. So a lot of the folks who are addicts, they think they're buying heroin, when in fact we've even seen heroin just be 100% fentanyl, which is truly, it's a death wish. If someone is injecting or even snorting heroin, but it's actually fentanyl, and they think it's heroin, they're going to use the same dosage. That's a death wish. And fentanyl metabolizes much quicker in their body than heroin does. So that means it takes first responders, they have a lot less time to reach that person, to provide them with Narcan, to take them to the emergency room for treatment. So that time that first responders would normally have to get that person help is drastically reduced. And it also, a variable is how much that they've taken, because fentanyl is measured in micrograms. And unfortunately, it can be absorbed through the skin. It's transdermal. It can be inhaled. All of those ways someone can overdose just almost immediately. And it's just not an addict. It could be a child that sees a package with powder in it. It could be a first responder. It could be anybody that doesn't know what they're handling. And certainly they can overdose from just a small amount.
Sure, and you know, a lot of the addictions begin with prescription pain medication. You know, maybe somebody was in a car accident, something like that. So Dr. Brooks, I know that you, of course, lost your son Lucas to a heroin overdose, but as a doctor, you kind of have a, you know, interesting perspective on addiction and, you know, prescribing pain medication. I know we've spoken a little bit about back in your training. If you'll tell us a little bit about that, kind of the push to deal with pain.
Sure. So back in 2001, there was a push to address pain for hospitalized patients, for all patients for that matter, and it was termed the pain as the fifth vital sign. And so physicians were charged with addressing pain with every patient that they saw to quantify the amount of pain they had and address it through means of prescription or other means. Most physicians then would opt to treat with prescribed narcotics, prescribed oxycodone, Percocets, etc. And I think probably that's where the start of maybe this crisis came about. Mm-hmm. And it sometimes was easier just to write a prescription to address the pain and not get to the underlying reasons that somebody was having pain. And so I think now that we've created that culture in medicine, it's hard to draw back and say we're going to not give you your pain medications anymore. And so I know with the PDMP, there's a big push to control that more, and that the pushback is coming from both the physicians and patients, I think, now, to say, hey, wait, we need our pain medications. And the physicians are saying, yeah, but wait, I'm going to get dinged on this if, the flag goes up and I've been writing too many prescriptions. How does it affect me as a physician? So it's really hard to find that line of, mm-hmm. Addressing it the right way, and not abuse the systems, I guess.
I want to ask you talked about the addiction, and addiction is a disease. I know there's still a lot of people that they think, well, just quit doing it. But one of our panelists tonight is a recovering drug addict, was in the throes of the addiction to opiates for a lot of years, been clean and sober for 4 years. Eddie, what do you say to somebody when they say, well, just quit taking the stuff?
For a lot of people, it's just not an option. When you're addicted to opiates, it's a completely physical and mental addiction, and you can mentally be ready to quit, but when you try, it's physical hell. You sweat, your body is in excruciating pain, and it's just so much easier to find opiates to make yourself feel better, and it happens instantly. As soon as you take the pill, mentally you're like, I took this medicine, I'm gonna start feeling better now. So some people can do it. I was able, after 8 rehab stays, to just quit cold turkey, and I went through the physical pain, and I think about that every day, so I don't ever go back to it, because like I said, it was physical hell.
And another kind of topic we discussed was, rehab. You said you went, was it 8 times you just said? The typical amount that somebody is going to rehab is 7 visits. Does anybody have any opinions on if rehab and how it works could be changed? Dr. Brooks?
So my only real experience with rehab was with my son.
Yeah.
For the month that he was in. And I did go to some of the meetings with him while he was in his rehabilitation setting. And it was pretty common to sit in those meetings and hear people talk about being in rehab for the 6th or 7th or 8th time. So I don't know if there's other issues that need to be addressed with the addict. It's a pretty short period of time to be in rehab. It's usually 3 or 4 weeks of period of time that they're in the actual rehab setting. It's kind of hard to get down to the core issues of why somebody uses in that period of time. It's hard to fortify somebody with the tools they need to stay clean in that period of time. So obviously aftercare is a really important thing. But I think that something that takes 7 or 8 times to get clean from might need a little tweaking. I'm not an expert in rehabilitation by any means. I'll never claim to be. But I do think there needs to be some issues addressed beyond just the physical and addiction to medications or drugs, alcohol, etc. I think until those issues are addressed with the addiction, I think it's going to be hard to keep somebody clean.
And it seems like one way to address it is to stop it even before it happens. There are 49 states that have a statewide prescription drug monitoring program. The lone exception is the state of Missouri, and that's where State Representative Holly Rader comes in. She's been pushing this prescription drug monitoring program for a couple of years now. It's yet to pass. And I'd be interested to hear from Mr. Derby too, but as you've looked at this in other states, how successful has the prescription drug monitoring programs been in stemming the tide of the abuse of prescribed opioids?
It's been highly successful. 74% of physicians in California said it changed their prescribing practices. And that's what we want, right? We want our physicians, our medical professionals to be able to look at this and say, okay, you know what, you're showing some signs of addiction and we need to reroute and change this. In Florida, 50% less prescriptions for methadone. So there are very great outcomes showing from the PDMPs. Now, are they a silver bullet? They are not. However, the ones with a physician mandate to check them before writing the narcotics certainly have shown better outcomes. But if I may address the question about the rehabilitation, you know, my daughter was an addict for 13 years, and she went from opiates to meth and then to whatever she could get her hands on to fill that, keep that pain from coming on, that sickness. And, you know, she went through multiple rehabilitation centers, was in prison for a few months in the 4-month shot treatment. And then when we got her into a long-term facility where she was gone for 6 months, she was able to get clean as far as physically, but then she had a holistic approach, which is extremely important, and that's with the mental health aspect of it, because you have to learn how to handle those triggers and what those triggers are, which is equally as important as being clean. And there's so much of the self-medicating to cover up the pain, the guilt that you feel that you've caused others, that you really have to learn. You really have to retrain your mind. You really have to learn, and for a 30-day, you know, and it took us many years to figure this out, and I was raised in addiction, but for a kid or an adult or anyone to go away for 30 days and come out thinking, okay, I've got this out of my system, I'm going to be fine, it just doesn't work that way.
And Mr. Derby, from a law enforcement point of view, do you think the law community as a whole supports the idea of a statewide prescription drug monitoring program?
We do, for a couple reasons. One example that I'll give you is mom and pop pharmacies, not the chain pharmacies that have their own internal communication system about communicating, you know, customers that come by regularly and get scripts for oxys or whatever the case. But the mom and pop pharmacies, they don't have that mechanism to know who's been to a doctor a number of times or who has went to different doctor shop. So with the PDMP, that provides them with a tool so that they could look up to find out if this individual has just, you know, filled 6 other scripts, you know, at other pharmacies. So I think that's invaluable. And the other point that I would add about it, and it's a misnomer, and just to back up a little bit, each PDMP from each state is different, but law enforcement does not use that as a tool to find people that are filling oxys. It's if for instance in the state of Kansas, if we wanted to get into the PDMP data to look at particular individuals, we'd have to have a federal grand jury subpoena. So we don't need that tool. It actually helps society plus law enforcement because it keeps down the folks that are doing the doctor shopping for all the scripts.
And absolutely, I mean, this crisis is so big now. We know this. You know, where is this stuff coming from? You know, how is it so readily available? I know, Eddie, you might be able to speak a little bit on, you know, how easy it was possibly for you to find drugs.
The main place that I was able to get pills from were people in the disabled community. They would sell their medication to supplement their income. And like he said, the prescriptions are expensive. You know, they can sell 1 pill for $20 and they have 60 pills. You know, that's a lot of money each month. I was also able to go to all the ERs here in Columbia and tell them, you know, I have a severe toothache, and I would be able to go to each one usually every couple months, you know, hit them all in one day, and then be able to go to the different pharmacies and fill those prescriptions.
And let me ask you this. We've touched on treatment. State Representative Holly Rader shared the story about her daughter. The doctor has shared some of the story about his son being in treatment. For you, did you end up going to treatment when you got clean?
Yeah, I ended up getting in trouble and was sent to the drug court program, which is a court-mandated thing that they're able to. It was a long-term treatment. You know, I was in there for a year, and they give you intense therapy. They drug test you constantly, randomly throughout the week. If you use, you go to prison. There's not second chances.
So when you went though, did you want to quit?
I was done. At that time, I was ready to quit. You know, my actions were just completely erratic at that point in my life. You know, and I was hurting my girlfriend at the time, my now wife, and my daughter, you know, my family, stealing pills from my grandmother who was sick, you know, like I had reached the end.
All right, so just the wanting to quit had a lot to do with it. Doctor, if you don't mind me asking you, you said your son went to treatment once?
Just one time.
Do you know, was he forced or did he want to go? Did he say, I've had enough?
He was forced by his dad.
Okay.
Yeah, to do rehab. So we had a frank conversation probably 2 months before I found out he was actually using heroin, because I knew he was using something. There was a change of behavior. He was burning through money quickly. You could just change in the look in his eyes. And so we had frank conversations, and I said, I know you're on something. Please tell me what it is. And I think in his mind, he was either ashamed, which is not uncommon, or he thought he could beat it on his own. And so he figured he could beat it on his own. So once he got arrested, was in jail. I left him in jail for a week. Let him stay in jail for a week. So he went through his detox in jail, which is a pretty safe place to go through detox. And then right from there, he went into rehab. So he didn't want to be in jail. He didn't. Just said we tried to do it your way, and it really didn't work so well. And so we're going to try it this way, and hopefully this will be better for you. So he got clean for a month. Once he was off the drugs, was free of the physical addiction, you could see the life back in his eyes, and we were able to have really great talks and conversations and talk about his future. So.
Yeah, and kind of back on the topic of where people are getting some of these drugs. Mr. Derby, I know we mentioned some things about the dark web. Is kind of a new level or element to people doing illegal things. Explain that and how it's been a challenge for your department.
Sure. Yeah, with heroin and prescription opiates, it's just not the standard way of obtaining them. So we see professional, if you will, organized burglary rings that move throughout the Midwest, breaking into pharmacies in the middle of the night. They'll collect all the Schedule II painkillers, move on to another state and avoid capture, truly move around the country, and then certainly they sell the opioids. We also see folks are using the dark web more and more to obtain all types of drugs, but specifically opioids, whether it's heroin, oxycodone, etc. And they hide behind that because with a lot of different types of encryption on a computer, it's hard for law enforcement to break into that and to even monitor it, because it's very labor intensive to as well as obtaining the necessary court orders to monitor that. So we just see people who are very ingenuitive nowadays to obtain opioids and heroin from different sources and different means.
So it sounds like the biggest thing we could do to help stop this opioid epidemic, if we can stop it, is to stop the use in the first place. Whether some people, and I know some people, they'll have a surgery, they have legitimate pain management issues, they get a legitimate prescription, and then they try to quit, and they realize they are physically addicted to these medications. They're basically synthetic heroines and morphines, as I understand it. Now, with the prescription drug monitoring program, for example, I lived in Florida when we enacted one there, and one of the positives, we did see that the abuse of opioids, of prescribed opioids, went down, but the use of heroin went up. Are we just moving the problem down the road? How would we combat that?
We're not. There is, when those are enacted, there is an uptick in heroin, but the opiates is the much larger problem, and so the decrease on the opiate side is so much more that you have a net gain of help there. What the PDMP, the most important part of the PDMP is that it's a clinical tool. And so your physician, your medical professionals can start seeing these signs on the front end and help divert that patient to where they don't get 6 months down the road or 2 years down the road and the kids have been removed from the home and they've lost their job and their life has hit the bottom. So trying to prevent them from getting to that point is what is most successful about the PDMP.
And I think one of the biggest issues, in my opinion, one of the reasons Missouri has yet to enact a prescription drug monitoring program statewide, privacy concerns. People don't want to be part of another database. How do you address that issue?
You know, the privacy concerns, so California enacted theirs in 1939. So that gives you a little bit of an understanding. These have been across the United States for many years, and there hasn't been a big outcry of privacy concerns. There hasn't been a big outcry. There hasn't been a lot of privacy breaches. These are electronic medical records, so they're covered by HIPAA law. And so they're federally protected. And you know, anyone who fills a prescription at Walgreens, at Walmart, at CVS, you're in a national database. And so when you kind of put it in perspective and you break it down to, you know, instead of the sky is falling scare tactics, and you really break it down to, okay, we're not authorizing anyone to see this information that isn't authorized today. You know, right now, if your physician feels that their patient has a problem, they call around to the pharmacies, they call around to the other doctors' offices and try to find out where all their patient is getting narcotics from. This just allows a simple tool for them to be able to look in and see that beforehand.
One of the things we hope to do tonight is, we all know there's a problem, but I think one of the goals that Hot Talk 93.9 The Eagle and ABC 17 has is, okay, how do we start to fix this problem? And that is something that we do want to cover during this town hall. A lot of people, they're baffled. They hear the horror stories about what heroin will do to you, what the problems that it causes in your life. Eddie, you've done the prescription opioids, you've done heroin. Can you talk very briefly, for somebody that's never done anything like that, can you describe as vividly as you can what that high is like?
The best way I can describe it is being out on a cold winter day and coming inside and sitting by a warm fire. You know, you feel a warmth creep up your body, a hug from someone that you lost long ago, the joy that it gives you, especially when you're sick and you're able to use again. It's just immense joy. It makes you happy. It makes you charismatic. It makes you just feel like you're on top of the world and you can, you know, talk to anybody, and it's just it really is an amazing feeling.
And I mean, I'm sure so many people look at you as, you know, a success story. You've been able to stay off of this. You know, what's it like for you now? Are you thinking about it every day? You know, how often is that in your mind?
You know, the whole opiate epidemic is really big right now, so you know, I hear about it all the time, so that really, you know, triggers thoughts in my head. But yeah, even without that, it is an everyday struggle thinking about how easily accessible they are, how I could go to the different ERs here in Columbia real quick and get prescriptions in an hour or under, you know, like heroin too is really easily accessible. It just takes asking a few of the right people in a few of the right neighborhoods, and you'll have it.
Right, well, Eddie, thank you. And we are actually going to take a little commercial break here. When we return, we'll be hearing from Washington about battling the opioid crisis right here in mid-Missouri.
We're also going to be sharing some questions and comments that we've been getting from folks in the community, some questions for the panel. That's when we return.
Battling the opioid crisis, a town hall meeting with ABC 17 News and Hot Talk 93.9. We'll be right back.
You're watching Battling the Opioid Crisis, a town hall with ABC 17 News and Hot Talk 93.9 The Eagle.
Hello. I'm so glad that ABC 17 and The Eagle are rallying together so that we can take on this very serious problem of drug addiction. The fact is, opioids are a major issue in Missouri. They end the dreams of young people before they have a chance to reach their potential. We are in a crisis. We need prescription drug monitoring programs, community involvement, student drug use prevention groups, and recovery programs. This issue is a priority of mine. Recently, I started the Drug-Free Missouri program, which includes helping counties begin drug recovery courts and holding high school assemblies across the 4th District warning about the dangers of drug addiction and challenging young people to be the generation that chooses to live drug-free. I know that we can make progress towards eradicating this growing problem. Together, we can make a real difference and save countless lives in Missouri.
Welcome back to Battling the Opioid Crisis, our town hall meeting with ABC 17 and Hot Talk 93.9 The Eagle. I'm Brendan Rutherford from Hot Talk 93.9 The Eagle.
And I'm Marissa Hollowed from ABC 17 News. We just heard from Representative Vicki Hartzler about the growing opioid and heroin crisis here in mid-Missouri.
So one of the things we've been doing as we try to move this conversation forward is for the past week, we've asked folks from the community to submit some questions, personal stories about the impact, because the victims of opiate abuse that come, it doesn't matter whether you're rich, poor, black, white, male, female, it just doesn't matter. And we've heard some pretty powerful stories this week.
Yeah, and we'd like to thank everybody that sent in their stories and questions. It is a tough topic to talk about, but talking about it is one thing that might make it better. So we thank you for that. The first story here is from Whitney. She says to us, "My brother's been fighting opioid drug addiction since he was a teenager. He went through treatment over 15 times, starting at the age of 16. He had periods of sobriety, but the drugs pulled him back in. Last year, we received a call that my brother had overdosed. As a result, he suffered a traumatic brain injury. My brother now requires full-time care. Not everyone who overdoses dies, but everyone who survives an overdose doesn't necessarily get to live."
We also heard from Pam, and she's talked about she's been living with this for 10 years. She's got a son. He played high school football and suffered a serious back injury. He gets a prescription for OxyContin, and within a matter of months, the kid's eating it, this stuff like candy, and the parents didn't have really any idea. The kid ends up going to rehab several times, ended up spending time in jail. He's 27 years old, and his mom says he is finally clean, but it's something he still struggles with.
Yeah, and we also hear from Kim tonight, who says, "My son has been addicted to prescription painkillers for almost 5 years. He's now a 26-year-old heroin addict. He began stealing from his family and others. My son was arrested twice for credit card fraud and is now serving 120 days. He's due to get out of prison at the end of July. I don't know what to do to help him stay off of heroin."
We also got several questions from viewers and listeners, some questions that they wanted to ask our panelists, which include State Representative Holly Rader, Troy Derby, who is a DEA agent, Dr. Brooks, and a recovering addict by the name of Eddie Bonnell has been kind enough to share his story tonight. One of the questions, and I think I'll start with Ms. Rader on this one. Where does an addict go? And this is from Cindy. Where does an addict go that wants help but they don't have health insurance?
Oh, great question. You know, there are many programs throughout each community, and they're different. So you check with your physician's office, check with your, and perhaps our doctor on the panel could give us a better answer. But there are resources throughout the community. The health clinics can help, get you to the right path. Each community is very different, though, in the resources that they have.
And I think another interesting point in one of these stories, in Whitney's story, is she talks about her brother overdosing, but when we think of overdoses, we typically think of someone passing away, but, needing full-time care. That just kind of puts it in a different place, I guess.
And I thought she told a very powerful story that even though he didn't die, the guy's for the rest of his life, it's affected him, and now it's affected his family. Another question: during peak seasonal allergy season, pharmacy can deny a purchase of decongestants like Allegra D, Claritin D. They can track these over the counter, but not opioids, and I think that's one of the things that we've been talking about. What's been the holdup in Jefferson City regarding a PDMP?
In Missouri, we have the power of filibuster in the Senate, and so we have had one senator for many years, and this is the first bill I believe was filed 12 years ago. And so this is something that has been reoccurring each year. I've been working on it for 5 years. And we've had one senator who has been extremely opposed to it and has filibustered, has threatened to filibuster, gotten other senators to help him. And so we have about 4 that are very passionate enough about it to stop it. Now this year he did say that with a physician mandate he would not filibuster, but then we had other senators that put amendments on that really weakened the PDMP, and so we weren't able to get it across the finish line because, you know, we have the many counties now that are passing a local program, which is going to be a statewide because they're all adding into the same database. And so it's going to be a statewide, but those counties that end up not getting on this will end up being the location that drug seekers go. And so, you know, we ended the session 2 weeks ago without a statewide, but we do at least have a county push going, and I know Columbia is one of the locations that's getting involved in that.
And would these be, I was at the pharmacy the other day and just out of curiosity asked them, are you, because we're in Columbia and I think Jefferson City, part of this drug monitoring program of Kansas City and St. Louis, and I asked the pharmacist, I said, are you guys taking part? And he says no. So would your idea be, you talked about, and I'm guessing you're talking about Senator Rob Schaaf when you talk about the filibusters, and am I right?
Yes, sir.
Okay.
I think we can assume, yeah.
So would part of what you want to see happen, would it be mandatory for doctors and pharmacists to be a part of this?
You know, so it is mandatory for pharmacists to, it's an electronic upload, daily upload, and that way any prescription that gets filled automatically goes into the system. They don't have to key in anything different. It's just as it's sending off to the insurance company, as it, you know, it also goes into the PDMP. And so on their end, it's not going to look different. However, on the physician end, many states have passed a physician mandate, and those are, the outcomes are much more successful. And so I'm for a physician mandate. However, all of the states that have passed it have passed a PDMP first, gotten that running smoothly, and then come back to the legislature to include a physician mandate. And so that's the preferred way to do it. Certainly it makes our program much stronger if we could do it all at once, but getting that language right has been the problem.
And Rob Schaaf.
Yeah.
Anyway, well, we have seen a number of, you know, law enforcement and first responders starting to carry Narcan, which can reverse the effects of an opiate overdose. You know, Mr. Derby, you might be able to speak on this. With Narcan being much more available within our departments and at pharmacies, you know, what kind of impact could this have?
The DEA views it as a positive impact. We've issued it to a number of our agents, so when we go out to search warrants, if we encounter someone who is overdosed, we could readily administer that to save their life and get medical attention. But by the same token, for first responders, it's important for us to have it. So if we're out and a fireman would ingest fentanyl, for instance, or some opioid, or police officer, or even a citizen, we have it, we're able to administer it, get them to an ER. So it's important in our eyes.
And we also talked about there's a new Narcan-resistant type of heroin that's out right now. That's pretty scary.
Yeah, I think perhaps the name might be a misnomer. It's not that fentanyl is Narcan resistant.
Okay.
It's because of the strength of fentanyl. Like I'd mentioned, it's say 100 times more potent than morphine. So it just takes more Narcan at more frequent administrations on the way to the hospital. So it still reacts to Narcan, but in greater volumes and more frequent.
One of the things that I've been curious about is because of the prescription epidemic with the opioids, there are people that have legitimate pain issues as a doctor, and I know pain management is not your specialty, but what does that do to people that legitimately need these pain meds? I mean, what I hear is people, they feel like criminals. They feel like, you know, people are looking down on them whenever they fill a prescription for a pain med or whenever they go to the doctor with a legitimate complaint of serious pain. How would, as a doctor, how do you handle that? What about the people that have legitimate needs for this?
That's a good question. It's really hard to objectify pain. You know, you can try a 0 to 10 scale or some kind of objective way of doing it, but everybody's idea of what pain is different. I think for myself, and I don't prescribe a lot of opioids, but when I do, I make sure that the person I'm prescribing them to understands that this is a deal between that person and myself, and then I would be the only person prescribing them. And if they can't comply with that, then I will not be able to prescribe them an opiate. Obviously, not everybody does that, and people find other ways around that system to go to different ERs or different physicians. I do think that's where the PDNP will be useful, is to prevent the doctor shopping and the what we call the medical tourism that I think you talked about in the week. But I think there has to be an agreement between a good relationship between the physician and the patient, a trusting relationship that says, I'm willing to help you. Here's your responsibility in this, is that I'll give you the prescription, but then I'm the only one giving you a prescription for pain medications.
Now, with your specialty is nephrology?
Correct.
So I'm guessing you do prescribe pain meds. If somebody comes to you and asks you for pain meds, or when you do prescribe, I mean, is it something where you kind of, look at them a little bit more closely and start to question?
Not in general. I think if I know the patient well enough, I get a pretty good sense of those people who are kind of seeking a prescription, drug seeking, and those who maybe aren't. And I know generally most of my patients that would need a narcotic pretty well to know what their needs are. So, can I circle back to a question that was asked earlier?
Absolutely.
Sorry. So there was a question asked about, for somebody who doesn't have insurance, what's available?
Yeah.
So this isn't a push for anything, but there's anywhere here in many towns, but for sure here in Columbia, and there's AA and Al-Anon meetings every night in different locations. And so it's important to, when somebody's going through this, whether you're the actual addict, the user, or family member, to have a group that you either be accountable to, that keeps you accountable, and that supports you. There's also online resources. So one of the resources I found when I was going through this with my son was a group called Compassionate Friends. And it's mainly online. They do have local chapters. I think there's one in Jefferson City. But it's even broken down into whether you're a family member of an alcoholic, family member of a cocaine addict, heroin addict, etc., or if you're a sibling of one of those, or if you're a parent of. So those are very useful programs, and it doesn't require any insurance. It does require internet access, but most people have that in their pocket.
Yeah, and there are a lot of the 12-step programs. There's even an NA, Narcotics Anonymous, and then the Al-Anon that the doctor was talking about is it's like a support group for people that have their lives have been affected by it. It is it's a good program, and I say that from personal experience. I know a lot of people, they go to Al-Anon and they're like, well, why do I have to go? I don't have the problem. It's a big help. Let me ask you, Eddie, did you utilize a 12-step program, or did you just quit after the legal trouble and all that stuff?
I had tried for a while, and it just wasn't for me. It was easier for me just to use my family and the clean friends that I had left, to use them as a support group and be able to stay clean. If you are looking for a rehab, there are a lot of state-run programs, especially here in Columbia. Google is an amazing tool to use when trying to find somewhere. It does take some time to get into them, but it is free, and they do help you.
And I think anyone that hasn't tried these drugs truly doesn't know the kind of impact it has. If somebody out here is watching today that's struggling through this, Eddie, what would you tell them?
I would tell them that they need to go ahead and be ready to get clean, because if you try and you're not ready, it's not going to work. You're going to keep hurting the people around you, because you'll just go back to using. It just takes time to be able to be ready and want to quit using, so you do it for yourself and not anybody else.
Yeah.
Let me ask you, from an addict's point of view, you were in it. You've been clean and sober for 4 years now. Congratulations. I know that's quite an achievement. Congrats on staying clean today. Your opinion, how do we stop the opioid epidemic?
I really think that the prescription monitoring drug program would help, because a lot of the drug addicts that I know, we all started really young with pills from our parents' cabinets, from friends' parents' cabinets, grandmas. It doesn't matter where you get them from, and we were all really young when we started. So I think if we implement something like that, it'll have less access, for kids to get pills, and we become heroin addicts.
Yeah, and speaking of, starting at a very young age, there is, the DARE programs, the Just Say No programs out there, of course, that are talking with kids at a young age, typically 5th, 6th grade. Is that the right time in a child's life to be addressing these issues?
Kids are going to be more exposed to these, I think, like what Eddie said, when they're teenagers. I don't know if they have the tools in place, or if they can recall their 5th grade experience and say, oh yeah, I could just say no. It's easy to say, it's easy to regurgitate, but I don't know if the head and the heart don't meet together, and you can't put it together or have the tools to know how to handle those situations. It's going to be really hard to overcome.
Okay, and I think we're going to take some audience questions right now too, so if anyone has a question out there.
Hot Talk 93.9 The Eagle and ABC 17. We continue with our opioid town hall meeting, battling the opioid crisis.
All right.
Hi, I'm Michael Trapp. I'm a city council representative here in the city of Columbia, and I am also a certified substance use disorder counselor. I wanted to make a statement and then ask a question. The statement is about that treatment is effective. The research is real clear that evidence-based treatment does change people's lives. And there is something to length of stay. So I appreciate that the panel brought that forward. The magic numbers are kind of 90 days and 6 months. The longer that people engage in treatment in general, the more successful their outcomes are going to be. And aftercare is critical, whether that's through a program or family support, church, mosque, synagogue, or through 12-step meetings. Those things are really critical. I wonder if anyone on the panel would like to talk about what I used to call stigma, but which I really want to start calling prejudice and discrimination, because it's not about your daughter or your son, and my deep condolences for your loss, or Eddie. It's about us and what we bring to it. And so I think calling it prejudice and discrimination is a start towards placing accountability where it needs to be, because we're really talking about just another chronic illness.
Right, exactly. And I think, I grew up with, my mother struggled with mental illness her whole life. And that is, when someone has heart disease, it's heart disease. We care about it. We care about them. When someone has mental illness, it's like, you kind of take another step back. If it's schizophrenia, if it's, and we've got to stop that. We've got to remove the stigma. We are all flawed bodies. We are all flawed humans. And so, and when someone gets lung cancer from smoking, when it's been on the pack of cigarettes the whole time, we don't say, hey, this is your problem, you did this. You knew the risk and you did this. But when an addict stumbles in their recovery, so often they're looked at as, they're never going to change. That's what they want. And we really need to remove the stigma, and that's one of the things that's been highly important to me as I go around the state and talk about this, is that removing the stigma and allowing us to have solutions out in the open is really going to help change the conversation.
Addiction is a disease, and I know, again, addiction's not your specialty, doctor, but can you talk about a little bit of addiction as a disease?
Sure. I completely agree with what Holly just said. We don't look at diabetics who don't take care of themselves, don't follow a diet, don't take their medications with anything but concern. We try to encourage them to take their medications and do the right things to take care of their disease, the disease of diabetes, or high blood pressure, whatever the disease is. Well, the disease of addiction requires intentionality. There's a process that you need to go through to keep yourself clean every day. There's people that you need to have around you to keep you compliant with staying off the drugs. So as a part of that disease, it requires you as the addict, the recovering addict, to practice that every day. And if you're not ready to do that, like Eddie said, you're gonna be fighting an uphill battle. And it's gonna take multiple times going through rehab until it finally sinks in.
I think we'll take another question from the audience.
Hi, my name is Ron Frost. I'm a partner in a healthcare consulting firm. My wife is a licensed clinical social worker, and she has had a focus in substance use
and abuse for a number of years. Before I actually ask my question, I'd like to frame it by reading a statement from an article that was published by the National Institute on Drug Abuse. The title of the article is "Prescription Opioid Use is a Risk Factor for Heroin Use." So here's the sentences I'd like us to think about. Quote, "Of people entering treatment for heroin addiction who began abusing opioids in the 1960s, more than 80% started with heroin. Of those who began abusing opioids in the 2000s, 75% reported that their first opioid was a prescription drug. Examining national-level general population heroin data, including those in treatment and not in treatment, nearly 80% of heroin users report using prescription opioids prior to becoming addicted to heroin." So my question is really directed to Representative Reeder and to any other legislators that might be tuned in tonight. Recognizing that where the current crop of heroin addicts are actually coming from, physicians' offices and prescribed medications, why are we underfunding efforts to assist the physicians in doing the thing we've asked them to do? 4 out of 5 addicts come through their doors. The process in going from being a prescription legitimate user of opioids to becoming a heroin addict does not take place overnight, nor does it take place in a vacuum where there are no signs. There are repeatable, predictable behavior traits that are available to be observed, and yet as a professional group, the medical industry, we have chosen, or our legislators have chosen, not to fund those efforts. Missouri received $10 million recently. Representative Reeder, how much of that would be allocated to PDMP or other things?
You know, I don't have the actual numbers, but that is all being allocated, I think a good portion of it into treatment. And I agree. I mean, we absolutely need to have more tools, and it needs to be more than just the PDMP, but the PDMP, I feel, is very much a cornerstone to build upon, as other states have. And so, you know, I couldn't agree more. We need to, I think, putting money into the front end of this will actually save the state money on the back end. You know, we have over 6,000 children removed from substance abuse homes, and that's a residual of this opioid epidemic that costs the state. When 75% of our incoming inmates in prison have substance use disorder, you know, long-term treatment costs a lot less expensive than the prison system, and much better outcomes. And so I think that we definitely need to start looking at what some of these other states have done that have become successful, and really help get people back onto a healthy lifestyle, because that, when you think about the children that are affected by this and the family members, there are just additional costs to the state that we could start curbing if we're putting the money in the right place.
All right, we only have a few more minutes here. We asked our recovering addict what he thought was the best way to battle the opioid epidemic. He supports a prescription drug monitoring program. We know where Ms. Rader is on that. Mr. Derby from the DEA, what are your thoughts on curbing the opioid epidemic?
Sure. DEA, some of our thoughts, and we have a trial run in 4 different major cities. One of them includes St. Louis, and it's a 3-pronged approach, and that is coordinated law enforcement approach with federal, state, and local law enforcement to attack the large organizations that are bringing narcotics, opioids, drugs, heroin into our country. 2 is working within private organizations to get the message out. And 3, diversion control, working closely with our doctors, pharmacists, making sure that they're aware of kind of like what the doctors talked about, some of the bad effects of prescription drugs once somebody gets started and what the end result is. So that's DEA's approach to curbing the problem.
Doctor, about 30 seconds. What are your thoughts on how we curb this?
I think education is a big part of it. Helping people understand that addiction is a disease, and you know, along with the PDMP, I think education has to be a part of that, and then steering people into rehabilitative services on whatever level, I think is going to be really important.
Great. Listen, we really we thank you guys. We want to thank our guests who agreed to come out tonight and be a part of this town hall on battling the opioid crisis. Thank you, guys.
Ms. Rader, thank you. Mr. Derby, Mr. Brooks, Mr. Bunnell, we really appreciate it. And this is such a growing crisis, such a big topic, so it's really important that we talk about it. And we can't thank you enough for taking the time to be with us tonight. And if you'd like to learn more about the opioid crisis, you can visit abc17news.com. You can click on the Battling the Opioid Crisis tab there for more information. We also have a very lengthy list of resources for addiction treatment. So we have all of that just kind of lumped together if you'd like to check it out.
You can also visit 939theeagle.com. We have interviews with Ms. Rader, Claire McCaskill, Attorney General Josh Hawley that all talk about potential solutions to fixing the problem. So you can check those out, 939theeagle.com. And again, we want to thank you for watching, listening, joining us, and the folks in the audience. Thank you for joining us on our town hall tonight.
And again, I'm Marissa Hollowed with ABC 17 News.
And I'm Brandon Rathert from Hot Talk 93.9 The Eagle.
Thanks so much for joining us tonight. We appreciate it.